What a morning we've had already. I think coming to music therapy conferences ought to come with a health warning: bring tissues. I've been weeping, smiling. What a morning. Thank you very much to the Music Therapy Trust for inviting me to speak. My name is Joanne Holmes. I'm a consultant child psychiatrist, and as you have heard, I work in an intensive Tier 4 CAMH service in Cambridge, covering the eastern part of England. And as Anne has said, I've had the privilege of working with Professor Amelia Oldfield over the 17 years that I've been in post. Amelia was there before me. She's our longest standing member of the team, actually. So anything that Amelia says basically goes, essentially. My task, I think, this morning is to talk about music therapy on the ground from a practitioner's point of view, a non-music therapist's point of view. So that's what I'm going to try and do. I probably will run out of time. I apologise. I'm going to cut into your lunch. We're running slightly late. But I've been told I'm allowed to walk at an allegro pace, is it? And you'll also all have to eat your meal in presto time. See, I've really tried. So, I'm going to gallop through, allegro style, where do creative therapies fit in CAMS, my perspective on this as a clinician. Why music therapy? Why is that important? I'm going to tell you a little bit about our clinical context so that you can see how it fits. And then I'm going to think about music therapy directly with children, music therapy and families, music therapy and the team and the organisation. We're having a particularly interesting time with our organisation in relationship to creative therapies at the moment. And I also have a video. I'm so glad I came with a video. And I'll just talk a little bit about a child that Amelia and I were involved with a couple of years ago. I won't have time for questions, but I am around all day, so do feel free to clobber me at lunchtime or later on. So, creative therapies. Christian was talking about the fact we don't know why music therapy works. I have no idea why antidepressants sometimes work. I have no idea why CBT sometimes works. I think we live in an environment where humans are incredibly complicated, but we can observe things that work and we can think about why they might be working and for those particular groups. My observations are that, and I work with under 13s, so my observations are mainly in that age group, that it's a particularly useful non-verbal or paraverbal treatment for younger children. CBT has become very, very fashionable in mental health over recent years. Mostly it started in adults and it's kind of filtered down into the childhood population. It works for some. The further down the age group you get, the less it works. And I think particularly for the children I see and many other children who are in community mental health services, actually very verbal therapies are not accessible. So we need to be thinking more broadly about other kind of ways of engaging children with play, with art, with drama, with music. It's particularly useful for children with developmental disorders. A quarter of the children I see have an autism spectrum condition or something similar. And it's also, I found, particularly useful for children with emotional blocks to their verbal communication. It's fun. God, we need fun. A lot of the children we see have very difficult, challenging lives with lots of hurdles to overcome, both for themselves and for their families. And actually having fun, and it's a normative activity. All children have musical experiences, both out of school, inside of school. So this is something that kind of fits for them. Most children don't come and sit and talk to a clinical psychologist for 45 minutes. It's part of their normal day-to-day activity. And it is particularly useful for those children who resist direct verbal therapies. A lot of the children who come into our service have failed to engage with a whole variety of psychological interventions, and particularly helpful for highly inhibited and anxious, controlling children. We are seeing increasing numbers of pre-pubertal children with anorexia nervosa. When I first started my job, as I say, a decade and a half ago, we probably had one child every couple of years with anorexia. We now always have at least one child on our unit with an eating disorder, quite often 2 or 3. Oh, brain scans. I'm a doctor. Give me a chance. So, preparing for this talk took me into realms of research that I don't usually look at, which is always good. And I found some scans. Don't worry, I don't understand them either. But actually, if you look just at the top left-hand scans, essentially what this study was doing was looking at the impact of music on children with autism, quite severe autism and learning disabilities, versus a control group. And what you're looking at, the round scans are when you kind of look across the brain, and the blobs, the other blobs, are looking sideways into the brain. Your language areas are on the left-hand side of your brain, the expressive bits at the front, the receptive bits further back. And essentially what these scans tell us is that children with autism respond less to speech, but those areas light up more when you play the music. So actually you are activating in the brain more bits of your brain when you're in a musical environment than when you're in a speech environment. This fits for me. Oh, wrong way. This is where we work. This is where Cambridge is. It's quite a long way from there to there. Very, very short flight though. So this is just to show you where the inpatient children's units are across the country. Those red stars are where they are. There aren't very many of them. There are 6 in England, 1 in Scotland, and you have a combined children and adolescent unit here in Northern Ireland. But as you can see, there are kind of large parts of the country. There's a random star in Wales. It doesn't exist. I just kind of lost it on the PowerPoint. There aren't. They would love one. Wales really needs a children's unit, so maybe it was a Freudian slip of my thing. But there aren't many inpatient services for children. That's a good thing. There aren't that many children who need inpatient treatment. But it's really bad luck for you if you live in Plymouth, or you live in Wales, or you live in the Orkneys. You've got a long way to go. If you really want to know about us, this is a book that we wrote as a team about our service and the kind of work that we do. And this was spearheaded by our music therapist, surprise, surprise. She gets us doing all sorts of things. But this is a book that's available. Who comes to see us? Children with high level of risk to themselves and risks to others. Children where they're in a position where there's significant harm to their well-being or development. Many of the children we see are out of school. Many of the children we see, their families are on the verge of breakdown or have broken down. So we may see children who are in care. And these are families who need intensive containment and support. And their needs sort of outstretch a community service. Now the Croft, I'm very proud of this, offer family admissions. We're the only children's unit that do this. So other children's units might have a kind of flat attached or local accommodation for families as to help children settle in. But we actually, when we arrange an admission, we say to the family, this will be for your child, and at least one, there needs to be a significant adult with them throughout their admission for most of the children. I personally don't think you can assess or treat children without their parents, particularly younger children. So this is predicated on the belief that we can't really assess children without seeing them as part of their families. It reduces the trauma of hospitalisation. It maintains those family relationships. It stops the hospital team taking over as parents, maintains that parental relationship, and gives us a fantastic opportunity both to understand the relationship between children and their families and also offer intensive parenting support. So if you are thinking about your local unit, try and get the parents in there. And it facilitates the admission of children at a younger age because you aren't doing that separation. What do we do? Lots of things. A really important part of our treatment is all of it's important obviously, but really engaging with families is the vital bit. If you can't engage, if they don't really feel that you understand their problems, you believe in them, and you believe they can change, then pack your bags and go home. Another really important part of what we do is establish safety. Many of the children, as I say, have extremely challenging behaviour. We have parents who've had broken limbs caused by their children, children who've injured themselves quite severely, families who don't feel safe. So parents who say, there's no point me telling my child to go to bed, there'll be such an outroar, we'll have a fight, I can't do it. So these are children where all the kind of norms of parental responsibility and authority have gone. So we offer containment, we get back those structures and routines into children's lives, we get them to bed. Bedtime routine is a kind of major focus of the work we do. We get them up in the morning, help their parents to do that, help the parents to make sure they brush their teeth, just those ordinary everyday things. Sit down at a table to have a meal, just those ordinary things. We obviously can offer multimodal assessments and multimodal interventions, and I'll talk about that a little more. And we have families together. We're a multifamily environment. And I'll talk a little bit more about that. So we can generate a holistic formulation that then informs the multi-agency care plan as children and the families leave and return to their lives. Most families stay with us on a Monday to Friday basis for about 6 to 8 weeks, so relatively short admissions. And obviously we have to support that transition. There's no point us doing lots of work to say, get a child going to sleep at night, if as soon as they return back to the community, everything's back where it started. Back again. I'm a bit dyspraxic. I'm not very good on left and right. Other things we do, really our job is to support the Tier 3 services and other services, education and social care. We offer second opinions where there's often quite a lot of conflict about complex diagnostic issues, consultations to team, and we offer training and we support research, including Amelia did her PhD whilst working on the unit, and I was privileged to be involved in that too. Privileged and oppressed. It was quite time consuming, but she's so enthusiastic, you just go along with it. Yes, of course, Amelia. So this is our biopsychosocial model, and outside of it, that I think all CAMS teams and mental health teams are using, but actually I think when I was thinking about this, I think there's a kind of substrate that sits on, that's that kind of human spirit that we don't talk about so much. It's the kind of creativity, the playfulness, spirituality, imagination. There's a big push, quite rightly, in mental health to look at things from a recovery perspective, to sort of really look for people's strengths and build on those strengths. And I think music therapy and creative therapies really play a really important part in that kind of substrate, building resilience for children and families. I mentioned multifamily group therapy. I'm just going to say a little bit more about it because I think it's really interesting and important. Our unit has been established for about 45 years. A guy, a marvellous psychiatrist called Aya Arson, talked about multifamily group therapy around the turn of the century, and I thought, we've been doing that for a long time. So he was doing it in a day patient setting, and he was emphasising that when you bring families together, you can generate all sorts of new interactions between families, and you can sort of harness the power of the group therapeutically. And his team use group therapy ideas, they use psychodynamic theory, they use attachment theory and behavioural theory approaches. So a real eclectic mix of really powerful, important kind of ideas around why children develop in the way they do, why families work the way they do. And he said that when you get families together in therapeutic environments, they families learn by seeing themselves or parts of themselves in others, reflected back. It facilitates social connectedness, it reduces stigma, and promotes reflective thinking. And that the families can act as consultants to each other. And this is our experience. So in our environment, where we might have 5 or 6 families working with their children admitted to our unit, we find that parents, so there's very interesting dynamics between parents and other people's children, and we find that parents can say things to each other that as professionals we can't say. So a couple of weeks in, we might be kind of working up with a family, noticing that maybe a mother isn't interacting very much with her child. She's on her mobile phone, he's off doing something naughty probably, she's not attending. And another parent will just turn around and say, oh, you don't seem to like your child very much, you don't spend much time with them, do you? And, you know, we've been spending 2 weeks thinking about how we're going to approach this problem. So we then walk in and say, oh, that's really interesting, that comment's been made, to sort of pick up the pieces, but that's a really helpful kind of, just an ordinary comment, real life feedback that parents get. Parents, usually at the end of their stay, I say to them, you know, what's been useful? What have you thought of family therapy? What have you thought of me? What have you thought of everything? And they always say that being with other parents has been the most important thing for them. They say, because these families are isolated, some of them are practically housebound by their child's difficulties. So actually just being with other parents, sharing a kitchen, going out for coffee together, finding out that their child isn't the only child in the universe with difficulties, learning together is a really important part of their treatment. I'm very privileged. I work in a well-resourced team. I appreciate that. Our community services in England, maybe similar to yourselves in Northern Ireland, are being stretched to very close to breaking point, in my opinion. But within our service, we have to have a wide range of therapists and staff really to contain the very challenging children that we work with. So these are the professions in our team. I always think on a Friday when we're having our ward round and all of these people are, I'm now feeling a bit like a conductor, you know. I think that might be the musical analogy. You're sort of trying to interweave all these therapeutic and assessment experiences and trying to make sense for the child and the family of what's going on for them. I would say probably our housekeeper, who's on that list, probably one of the most important. But if you really want to know what's going on in our unit, you go and talk to our housekeeper, who makes lunch for us all, and she knows what's going on. The people who have missed out, and they would shoot me if they were here, are our administrators. Without them, we wouldn't have a unit, so I do apologise. So, a bit more focused on music therapy. So this is the thing, all of the children on our unit have a group session on a weekly basis. It's part of the structured programme. We have school in the morning and different therapeutic groups in the afternoon. And I think it does really reflect a normal curriculum, so children would expect to have music or something like that within a school programme. It's a real opportunity to promote relationship building between the children, to build their social interactions and to promote that emotional communication, and it also serves a great assessment function. And children also, not all of them, most of the children will have individual sessions, and some will have individual therapy. Amelia has developed a music therapy diagnostic assessment. That was her PhD, and this was developed alongside an assessment called the ADOS, which is a kind of gold standard direct assessment of children looking for symptoms of autism spectrum condition. There are very large numbers of children where this is a question in their diagnostic question. Fascinating. Amelia and I have quite interesting discussions about how these two assessments work, and they're actually very complementary. So there are some children who won't do an ADOS. So the ADOS involves being with me for half an hour, so that's partly problematic for them. It is a talk and play-based assessment, but still there's quite a verbal demand in the ADOS, whereas children, when they do an MTDA, it's a largely non-verbal assessment and much more easily accessible. And I don't think they spot so easily they're being assessed. So it's really good for some children. And also the music elicits more of the repetitive and stereotype behaviours. Fascinating. So you get children who will be using instruments in a specific way or wanting to know how the instruments work or being very repetitive in their play in a way that I don't elicit in the assessment that I do. So again, a very useful kind of, as I say, complementary and convergent assessment, and particularly when we're talking to families who are often very convinced their children have autism, it's very useful for me to be able to say, well, I've done this assessment, this showed this, and also there are these other assessments and evidence. And as I say, so that's the assessment function. And also we do short-term goal-based therapy to address a range of issues for the children who are working with the service. So that might be things like improving emotional expression, particularly useful for children with anorexia, who tend to start their music sessions very quietly, often playing a triangle. And when at the end of their treatment you can hear them halfway across the unit and you can hear the drums, you really know you've made a positive therapeutic difference. It's great for activation and motivation, particularly for the children with depression, which fits really well into your research this morning. It's not a surprise to me to hear that mood and self-esteem are really key outcomes for music therapy. It's certainly my clinical experience. And it really, again, linking with your research, the promotion of improved confidence and self-esteem. A lot of the children that we work with, and I'm sure that CAM services here work with, have experienced high levels of trauma, bullying, abuse, neglect, all sorts of traumatic experiences. Families and music therapy. So we have families on tap. We're very lucky. We kind of have them imprisoned with us for 6 weeks. So we can really encourage them to get involved in their children's therapy. And a lot of our therapies are for children and parents together. And that's really good to promote positive experiences and improve the attachment between parents and children. Parents find it much more difficult to engage with music therapy than children. Children are much more open to this, much more willing to give it a go, much less self-conscious. And you can imagine maybe a mum who's depressed or has social anxiety or has had lots of difficult experiences in her life, and they're inveigled into the music room and really kind of discover a whole new part of themselves, as well as new parts of their experience with their children. And it does promote that non-verbal communication. A lot of the parents we work with talk a lot to their children, don't listen so much to them, aren't really thinking about the children's experience because maybe their own experiences are so overwhelming. And actually, again, you put them in a music room, you kind of take out the verbal bit and you actually say, okay, so what's your child doing? What do they look like? What's their expression? And the video feedback, so Amelia or her colleague might take videos of sessions and then look at those together with the parent to really, ask the parent to really think about what they can see in those sessions and find the fantastic moments. And it's fun. And actually it's a way to model positive interactions for parents. A lot of the parents we work with have been very poorly parented themselves. They have no models to draw on of positive child involvement. And music therapy can be a fantastic way of kind of, really modelling positives as well as boundary setting and so on. The team. I managed to get through 5 years of medical school and about 8 years or 9 years of post-graduate medical training without meeting a music therapist or coming across one or really even hearing about music therapy. This back is, as my children tell me, when dinosaurs, roamed the earth, as you can imagine. So it was a while ago, but I think still it's really hard for doctors particularly, but other health professionals to really understand what music therapy is about. And really you do need to see it, don't you? You need to see those video clips, you need to kind of feel it. It took me a long time to get to music therapy, and I've been learning about it for many years. And also I think it does have an impact on the whole team, it's not just the direct clinical work. Certainly in our ward rounds, there's almost a standing joke. We rate the children on an outcome scale each week from 0 to 100. It's an interesting exercise of trying to get your team to agree, and almost always Amelia and her colleague Andrew will have a different number to everybody else. Tricky. So we now have a different column for them. So there's a kind of music therapy, CGAS, and everybody else. And that's because often they have a very different experience with the child, which is a really useful experience. And also it can be very helpful to the rest of the team to hear maybe that in the music room the child has been cooperative and imaginative and creative, and the rest of the week the nursing team have been struggling to get them to kind of sit down or, follow a rule or what have you. But actually that does help people to kind of move away from that kind of, this is a child with X, whatever, autism, conduct disorder, whatever the particular label that they have might be. I've talked about that additional assessment material that compares and contrasts and the emphasis on non-verbal interactions. And also, our music room is well used outside of music therapy sessions, and staff will be going into the music room with children, and parents will too. And we have non-music therapy staff involved in those music therapy sessions, so the kind of skills of the music therapist can be disseminated through the team, and that's great. And it really encourages that kind of creative approach. I think health teams, we can get very stuck in our health tasks. Have we made the diagnosis? Have we had the trial of methylphenidate? Whatever it might be. And actually, both music, and we're very privileged at the moment. We have a drama therapist working with us for a bit of time, and sometimes we can access art therapy. These kind of interventions can help everybody be more creative. As I say, we've got a book due to music therapy. We also have a DVD. Creative people in your team do stretch you outside of your boundaries. I certainly know that. And there's this therapeutic symbiosis. That's quite hard to say, actually. It's easier to write. So I think, as was mentioned before, I think in your clips from your other therapists, sometimes music can kind of activate a child or a system and allow other therapies to work, essentially. So quite often in our when children are leaving the unit, they'll often have a combination of, say, music therapy with family therapy or music therapy with behavioural therapy ongoing. And it creates that kind of really nice balance and continues to consolidate that kind of positive approach to the child. Music in the wider world. So, music also, through our music therapists, we have links with schools, with charitable organisations, other creative therapies, training organisations, and links with research initiatives. So Amelia is linked in with this very large trial looking at outcomes for children with autism. This is all lovely, but we've just been through quite a difficult year in our trust. Our trust, like all health services, is looking for cutbacks, and our entire creative therapy department were under threat. And at one point during the year, our trust seemed to be saying, we're just going to sack everybody and we'll just employ people as and when. So clinicians can make a case that a particular person will have a creative therapy. We've had to argue really hard. Fortunately, during the consultation, the trust said that they've had more responses to this consultation than any other consultation they've ever put out before. They had so many, they had international responses, that they had to get translators to translate. So they've retrenched on that position, but creative therapies are under threat. That's the reality. All sorts of things in the health service are under threat. So that's why it's so pertinent that your research comes at such a pertinent time to kind of support the work of creative therapies and really remind people these are therapies that work, and they work for people who don't respond to other things as well. So, just time, great. I'm just going to tell you about a little girl called O, and she's 9. She came to our unit about a couple of years ago. She had a history of very long-standing emotional and behavioural problems. There'd been lots of discussion about her diagnosis. She'd been diagnosed with ADHD at some point, and medications had been tried, but they made no difference. At school, she was really struggling with her friendships. They were often breaking down. She was either saying she was being bullied or she was being accused of bullying. She had an extremely conflictual relationship with her mother, which involved both verbal and physical aggression both ways, and physical aggression from the child to the mother. And she talked about being so miserable that she wanted to die. Quite often, she talked about that. Her mother was absolutely convinced that she had an underlying developmental disorder that had been missed by the services, by the community services, and she thought it was either autism spectrum disorder or a condition called pathological demand avoidance. You can ask me about what I think about that at lunchtime if you want to. I have strong thoughts on it. In terms of family relationships, there was also the maternal grandmother was very important. We do find grandparents are really important for good and evil. And our family therapist has quite a sort of mission on to both get fathers onto the unit and grandparents, because often those are the people who are really kind of holding the family script of what everything means. And this maternal grandmother had a very firm belief that she had this neurodevelopmental condition, and what that meant was that how they'd interpreted that was that O couldn't control her behaviours, that these were all down to this condition, and that they had to adapt to them, they had to accept them. So this little girl, they were not putting any boundaries around her behaviour. She was kind of in an incredibly powerful position, but feeling incredibly anxious and miserable at the same time. This won't surprise you that there was a family history of disrupted care. Mum's parents had separated when she was young, and she'd kind of been sent from one parent to another. She was quite a feisty, challenging child, and as soon as one parent got fed up with her, she was shipped off, in fact, to the States where her father was living. She'd be there for a year or so, she'd get shipped back. So this was a woman who had a kind of really disrupted sense of who she was and whether she was lovable, really. And Mum had a very idealised view of her own mum, sort of said she was wonderful despite all this kind of toing and froing her in her own childhood. But actually, when we met Grandma, she was quite critical of Mum and very undermining of her. And of course, Mum was therefore desperate to have she was desperate to have a different relationship with her own children. She had an older daughter who was the golden child, who was actually Mum's friend, really, and then she had this kind of scapegoated child. And she really had a really low sense of her own mothering and sense of competence as a parent. And she said to me very early on, well, if it's not autism, I'm a crap mum, and that's that. You know, you just thought, those are two very difficult options. So what happened to O on the unit? Obviously, she went to our school. She gradually settled. She was gaining confidence there. She was quite a challenging, feisty little girl, I have to say. She was quite bossy, and she really liked to have a lot of adult attention and needed lots of reassurance that she could do things. She gradually made a good relationship with her key workers and talked in her individual sessions about friendship difficulties and guilty feelings about upsetting family members. In family therapy, they explored the themes of mum's own experience and not being the perfect mum, and there was a real focus on building mum's self-esteem. And in those sessions, Mum she talked very early about kind of noticing that O wasn't as challenging as other children on the unit, and we did have a little boy with autism at the time, and I think it was kind of dawning on Mum, this looks quite different to my child. And she kind of, went through a phase of really feeling unsure and should she be at the unit and what have you. I did an ADOS, which I've mentioned to you, and actually this little girl, I think she scored 0, which is quite hard to do, actually. Most people score 1 or 2 but actually she has extremely good social understanding. She's highly attuned to emotions, as you can imagine, and highly aware of social relationships. I also did something called a story STEM assessment, which is a kind of another play assessment where you look at family relationships with the child, and that showed she had themes of kind of sibling rivalry with her kind of golden sister and ambivalent parent-child relationships. So she'd kind of portray the mum figure in the story as kind of looking after the babies. But actually what she was doing, she'd say, oh, mum's giving the baby a bath, but what she played out was the mum kind of beating the baby into the bath, so slightly worrying. She had very good concentration. She didn't have any symptoms of ADHD. We looked at her IQ because that had been a worry. She was fine, and our psychologist started working with mum using a cognitive analytical approach, looking at her experience of roles within relationships. Just missed one out, haven't I? And in the parenting multifamily group work, mum started in defensive mode, as I say, attributing all of her daughter's problems to neurodevelopmental problems, but midway through the admission started to become a lot more reflective and thoughtful of her own and other people's experiences, and other parents were able to point out some unhelpful patterns between mum and her daughter, but also to praise mum. So to emphasise how committed she was to her daughter, which she was. And the music therapy sessions showed really low scores on the MTDA and subclinical scores for ADHD and emotional problems. And the individual work, I'm going to show you a little clip of that, which hopefully will work. Ooh. Is it going to work? Everybody else's videos worked. I'm feeling paranoid now. Sorry, Amelia, I shouldn't really have ended on that point where you say I'm muddled, should I? That was a bit cruel. I should say, I should have said before that within that session, it's a improvisational storytelling task, and the child starts off, and she started off saying, it's a couple of girls going to the park to play, and then Amelia introduces a crocodile. So then, how does the child react to the crocodile? She, as you can see, quite a dramatic little girl. I think she has, good chance in musical theatre, doesn't she? So just our last couple of slides, really. So I guess I have the privilege of working in a team where we can translate musical therapy into practice pragmatically. We can use those structured diagnostic assessments. We can be promoting social interaction in children with autism spectrum disorders and working with other children. And really promoting secure attachment and rebuilding positive family relationships. Going back again, can't get. And I'm going to leave the last words for Olivia's mum. It was very sweet. They came back to the unit about a year after they'd left, and they wanted to come back because they'd done a lot of work after they'd left. I think a lot of people do the work after the therapy. Or the intensive phase of the therapy, and she wrote to us just her thoughts on her admission, and as you can see, she said she was dreading coming to the Croft, worried she'd be judged, thinking she wasn't a good mum. She wanted people to see what she was dealing with, this girl, and how hard it was, and she was proud that she stuck through it. She highlighted a particular member of staff who'd kind of taught her how to kind of manage her daughter, manage her challenging behaviour. She taught me to believe in myself, picking my battles, strategies are still working, and I love this bit, we're doing art and craft at home and loving papier-mâché, and I feel more on top of things. So that's what keeps us going, isn't it? Thank you very much, enjoy your lunch.